The inoculum effect of antibiotic susceptibility testing is often discussed at plate rounds and infectious diseases conferences, but many of us don't really have a clear definition of what it is or a good understanding of its significance. We'll be talking about the inoculum effect and susceptibility testing of Staphylococcus aureus with cefazolin. Some of the questions we'll discuss are: what exactly is the inoculum effect and how is it measured? Does the inoculum effect have clinical significance? And how common is the inoculum effect with Staphylococcus aureus? Welcome to a very last-minute episode of Editors in Conversation. This episode is brought to you by the Journal of Clinical Microbiology, available at jcm.asm.org, and on Twitter at jclinmicro. I'm your co-host, JCM Editor-in-Chief Alex McAdam. This podcast is supported by the American Society for Microbiology, which publishes JCM. Please subscribe to the podcast and rate or review it. I am joined, as always, by my co-host and a fellow editor of JCM, Dr. Ellie Thiel from the Mayo Clinic. This is when I usually ask you how you are, Ellie, but we ran into each other earlier this morning because we're both in Chicago for the American Association of Clinical Chemists meeting. So I know you're doing well.
I am. I'm doing great.
Good. You've recovered from microbe?
I have. Microbe was good. Some great sessions. A lot of people finally got to meet each other again after how many years apart. So microbe was good. And our podcast recording went well. From the perspective that people did not walk away halfway through. So I think it was great.
I thought it went extremely well. And people should check out that episode. Ellie hosted a live podcast. Bobby Pritt was our guest, and we talked about parasites. It was a lot of fun. So if you haven't heard that one already, go ahead and check it out. So we are scrambling a bit. We are lucky to have Dr. Tanis Dingle joining us. Tanis is a clinical microbiologist at Alberta Precision Laboratories, public health laboratory. She is a clinical associate professor in the Department of Pathology and Laboratory Medicine in the Cumming School of Medicine at the University of Calgary. Tanis, welcome to the podcast. Thanks very much for joining us.
Thanks so much for having me. I'm so excited to be here. I'm an avid listener.
Oh, that's great to hear. We are hoping to be joined very soon by our friend Dr. Susan Butler-Wu, who will be making a return appearance. She is caught in, not surprisingly, Los Angeles traffic. So we look forward to Susan joining us. We may move some of the questions around, and Tanis has generously agreed to answer some of the questions that we originally slated for Susan. So if it's a bit of a scramble, you will all understand. So I'm going to jump right in. So Tanis, you and Susan are first and senior author, along with several others, from the CLSI cefazolin high inoculum ad hoc working group. And you have a paper in the current issue of JCM, which is titled Prevalence and Characterization of the Cefazolin Inoculum Effect in North American Methicillin-Susceptible Staphylococcus aureus Isolates. And we will post a link to that paper in the show notes. So, Tanis, our first question is, what is the role of cefazolin testing? What is the role in cefazolin in treating infections caused by Staphylococcus aureus?
Yeah, thanks for that question. So cefazolin is one of the first-line agents to treat methicillin-susceptible Staph aureus infections, along with anti-staphylococcal penicillins, such as nafcillin, oxacillin, cloxacillin, depending on where you are in the world. So cefazolin has shown benefits for treating MSSA infections over anti-staphylococcal penicillins, including less adverse events, a more favorable dosing schedule, and lower cost. However, whether cefazolin is actually a preferred treatment over anti-staphylococcal penicillins is controversial and really remains an open question. And so one of the reasons why it remains an open question is actually the topic of our conversation today.
Excellent. And people often bring up the inoculum effect, as I said in the intro, in infectious disease conferences or plate rounds. But I think many of us don't really have a clear definition of what we mean when we're talking about the inoculum effect with antimicrobial susceptibility testing. So what is the inoculum effect?
So in the simplest terms, the inoculum effect results in elevated minimum inhibitory concentrations in proportion to the number of bacteria present in the inoculum. So as you increase the inoculum, the MICs increase. And so in vivo, the inoculum effect can occur in infections where high concentrations of bacteria are present. So think infections like endocarditis, osteomyelitis, complicated abscesses, pneumonias, things like that.
Thank you. And we'll be talking about the clinical significance of the inoculum effect a little bit later in the podcast. We're going to come back to that. But first, I wanted to talk to you about why the CLSI decided to tackle the question of the inoculum effect. Why had they established this working group in the first place?
That's a great question. So back in, I think it was January 2019, Dr. Cesar Aureus and Dr. William Miller, who were out of the University of Texas at the time, they had come and given a presentation to the CLSI Methods Development and Standardization Working Group. And they had just published a paper on the outcomes of patients with infections that are positive for the cefazolin inoculum effect in Latin American patients. And they had shown that there was increased mortality and disease severity in these patients. And so they had presented to our working group and had suggested that perhaps CLSI should work on a test to more rapidly detect the cefazolin inoculum effect. And so the methods development working group kind of took that away and decided to develop an ad hoc working group to work on whether this is something we should be recommending to clinical laboratories.
Got it. And Cesar, of course, hosts this podcast as well. And does the every other episode for us. So let's see. So next, let's talk a little bit about how you measure the inoculum effect. How can we determine whether a specific isolate of Staph aureus demonstrates the inoculum effect?
So that's done by broth microdilution. So essentially what you do is you test the isolate in the standard way at the standard inoculum, which is 5 times 10 to the 5 CFUs per mil by broth microdilution. So you have a varying concentration of cefazolin antibiotic tested at the standard concentration as recommended by CLSI. And then you also test it at a high inoculum, which is about 100 times more than the standard inoculum. So 5 times 10 to the 7th CFUs per mil. And you do the exact same test on the exact same broth microdilution tray, and you look at the difference in MIC. So at standard inoculum, you would expect the isolates, since the MSSA isolate, to test in the susceptible range, even though we know there's not actually a susceptible break point. It would have a low MIC. And then at the high inoculum, what we expect is an MIC of greater or equal to 16 micrograms per mil. And so, as you can imagine, this is not really feasible for most clinical laboratories, unfortunately. And so that's why this working group kind of got set up, was to try to develop a more rapid and feasible method to be able to detect this cefazolin inoculum effect in clinical laboratories.
So is the infeasibility of it because it is broth microdilution, which is a relatively labor-intensive method of susceptibility testing?
Yeah, you got it. It's labor intensive and does require a very specific skill set that I think a lot of clinical laboratories don't necessarily have.
Yeah.
So I'm curious, are there any other AST susceptibility patterns that would kind of suggest or be suggestive of a cefazolin inoculum effect, or is this the only marker?
So that's a good question, and I don't think that's well enough studied yet. So no. So things like, people have suggested to us, why not just do a beta-lactamase test? Because we know that the isolates that have the cefazolin inoculum effect also have the BLA-Z enzyme. And why not just do a nitrocefin disc test? And the problem is that you can't do that because greater than 90% of MSSA isolates have the BLA-Z enzyme, and not all of them, unfortunately, have the cefazolin inoculum effect. So it's not that straightforward. Whether there's other drugs or antibiotic susceptibility you can look at is, I don't think we know, in fact, whether there is anything else you can look at.
Sure.
So just to recap a few things, you measure the inoculum effect by looking at the change in the MIC at a low inoculum compared to a high inoculum. And if you see an increase in the MIC with that higher inoculum, that's the inoculum effect.
Yes, and so it's specifically defined as greater or equal to 16 micrograms per mil at the high inoculum.
Got it. And right now, that's the only method that's well established. Am I right in thinking that this working group, if it decides that this is a significant problem and that they should tackle it, that they will be trying to figure out a more accessible method for detecting this effect?
You're absolutely right. And we've actually made quite a bit of progress on it. And we're still working on it, though. So Dr. Aureus's group has actually already published a rapid cefazolin inoculum effect method. However, it's still, unfortunately, not perfectly feasible for clinical laboratories because it requires setting up of ampicillin in solution as well as nitrocefin solution. So it kind of reminds me a little bit of the CARBA-NP test, where it can still be a little bit tricky for clinical labs. So we're actually working on 2 other methods right now to try to make this a little bit more feasible for clinical laboratories.
Very interesting. Well, we'll have to have you back and Susan back once you have the paper on those methods.
Yeah.
So, Tanis, how did you investigate? Because your paper is primarily about epidemiology. You were looking at how common the inoculum effect is. So, what was the study design? How did you investigate that?
Yeah. So this was actually one of our first objectives as our ad hoc working group was formed, was how prevalent is this problem in North America? Do we even need to worry about it? And so we designed this study in a pretty straightforward way. So our primary objective was to determine the prevalence of the inoculum effect in North American MSSA isolates. And so to do this, we had 7 clinical laboratories contribute sterile site MSSA isolates for a total of 305 isolates. Our study sites were 6 laboratories in the United States and 1 in Canada. And the 6 labs in the United States span geographical areas of the United States. So we had laboratories in Los Angeles, Houston, St. Louis, New York City, and Evansville, Indiana. And then the Canadian laboratory was actually the laboratory that I work in Edmonton, Alberta, Canada. And so isolates were collected in the first 6 months of 2019. And then they were all sent to a single laboratory to get tested by that gold standard cefazolin inoculum effect method, broth microdilution method, in triplicate.
And was it all comers for isolates of MSSA from sterile sites?
So it was all blood culture, consecutive blood culture, unique isolates. I think I probably said sterile site. I meant blood culture isolates, consecutive isolates. And each laboratory we asked to contribute kind of between 30 and 50 isolates.
Got it. And when you say unique, meaning that if the patient had a second culture that was positive, you only took the first.
That's exactly right. Yeah.
Got it. All right. And what did you find for the epidemiology part of the study?
Yeah, so I think this was the most interesting part of the study. Was that 18.6% of the isolates that we tested, so that was 57 out of 305, were positive for the cefazolin inoculum effect. And the prevalence or the positivity ranged depending on the site. So the University of Texas, for example, had 0% cefazolin inoculum effect positive isolates, whereas the laboratory in Edmonton had 27.9% positivity rate for the cefazolin inoculum effect. And that the rates really ranged across study sites, but I would say mostly it was between 20 and 28%, depending on the site. The lowest rates were at the University of Texas, as I mentioned, at 0% positivity. And the other lowest was at the Children's Hospital of Los Angeles at 9.8% positivity. But we did do some statistics, and there was no association between geographical location and cefazolin inoculum effect positive isolates.
It was kind of a striking variation in the percentage that showed the inoculum effect. And it's not the method, right? Because you pointed out that they all were tested in one laboratory for the inoculum effect. What do you think well, you just said there's no statistically significant difference, and here I am asking what explains the difference, which isn't exactly fair. But any thoughts about why that variation might have occurred?
Well, we did try to look to see what type of centers these isolates were coming from. So the Children's Hospital of Los Angeles, that was our only pediatric specific site. So we thought maybe that could be it. But then the University of Texas Health Science Center is an academic teaching hospital like most of the other sites. So we're really not sure why that was. Maybe it was just luck of the draw for the isolates that we ended up getting from that site.
Got it. So still a little bit of a mystery there, although statistics says otherwise. And then you also looked at the MICs for the isolates that did or did not show the inoculum effect. And what did you find when you looked at those MICs?
Yeah, so we looked at the standard and high inoculum MICs for the cefazolin inoculum effect negative isolates and the cefazolin inoculum effect positive isolates. And I think the most significant difference was that the cefazolin inoculum effect negative isolates, that standard inoculum, had a lower geometric mean MIC at 0.39, whereas those that were cefazolin inoculum effect positive had a standard inoculum geographic mean MIC of 0.6. So it was slightly higher in the cefazolin inoculum effect positive isolates, but this is not something that laboratories could just say, the MIC of my isolate is, a little bit higher, so it must have the cefazolin inoculum effect. There's not really no specific MIC at standard inoculum that will indicate, that this isolate has the inoculum effect. And wouldn't that be nice? But there isn't.
It would be tricky to reliably measure such small differences in MICs in any case.
That's exactly right. That's exactly right. And really the ranges for the standard inoculum MICs between the positive and negative isolates didn't differ at all.
Gotcha. And then you also did something that I thought was quite remarkable, which was to do whole genome sequencing on many of the isolates. Not all of them, I don't think, but many of them to try to get at any differences between the ones that showed the inoculum effect and ones that did not. What did you find when you looked at that?
Yeah, so we ended up sequencing about 82 of those isolates. So 55 of them had the inoculum effect and 27 of them did not. And we found that all of the isolates, whether they had the inoculum effect or not, carried the BLASI enzyme. And that we know, as I said before, that greater than 90% of MSSA isolates do have that BLASI enzyme. And then we kind of looked at the type of enzyme that was there. So the BLASI enzyme has 4 different isotypes, A, B, C, and D. And we know in the literature that A and C seem to be the most common types to carry the cefazolin inoculum effect, and that was the case in our isolates. So 44% were BLASI type A, and 53.9% were BLASI type C, and that was for the inoculum effect positive isolates. We also looked at the sequence types of the isolates, and we found that sequence type 30 and sequence type 8 were the most commonly found in the cefazolin inoculum effect positive isolates. And this was also consistent with other studies that have been published where sequence type 30 and sequence type 8 seem to be associated with the cefazolin inoculum effect. But overall, there was no association between the BLASI type or sequence type with geographical location. We were hoping maybe, there might be more type A in certain geographical locations or more type C in others, but there was not.
So I'm curious, Tanis, what do you think is the mechanism really behind inoculum effect? It doesn't really seem that maybe carrying the BLASI genes would be it, since we see it in both MSSA with and without inoculum effect. So what are your thoughts on a possible mechanism?
And I think that is the big question. Nobody really knows what it is. There are groups that are working on it, but nobody knows why this occurs in only some of the isolates that are carrying this enzyme. So so there are studies ongoing to look at the molecular mechanism behind it, but really we don't know at this point. And again, wouldn't that be nice to know? Because then it would help us develop an assay potentially. And so anyway, we don't know at this point.
But it looks like sequencing and looking for Blasi is not going to be it.
That's definitely not going to be it, unfortunately.
This may be a simple-minded question, but the fact that there wasn't any kind of genetic association made me wonder, is this a stable characteristic of the isolate? If you take the same isolate and test it over and over again, will it continue to show the inoculum effect versus one that doesn't have it? Will it continue to not have it?
Yeah, so we've actually been using the same set of isolates in looking at the performance of our rapid assays, and the isolates seem to have a pretty stable phenotype. So, so yes, it looks like they are. It is a stable phenotype. Yeah.
Good. I was pretty confident you guys had looked at that.
Yeah.
Good thing to double check.
Yeah. Susan hasn't joined us. Tanis, I appreciate, we talked about this before we started, and you kindly agreed to take on some of the questions that we had planned for Susan. So I'll ask you to tell us a little bit about what is known about the clinical significance of the inoculum effect.
Yeah, so in terms of the clinical significance, again, wouldn't it be nice if it was just that straightforward and we can say, the cefazolin inoculum effect, if you have a patient with an MSSA infection, a deep-seated MSSA infection that has this phenotype, that they have poor outcomes. Unfortunately, the literature is mixed on this issue. So there have been studies that have found no correlation between the presence of the inoculum effect and clinical outcomes, but then there have also been some nice clinical studies that have associated the inoculum effect with treatment failure, particularly in patients with deep-seated MSSA infections. And also they have correlated the inoculum effect with increased disease severity and mortality. So there are some nice studies that do show a correlation, but then there's also some nice studies that don't. So we don't know the answer to this. And I think this is something that we would really like to see, is a really well-designed randomized control study, prospective randomized control study that looks at this issue and looks at the treatments that are given to the patients as well, just to hopefully come to a conclusive interpretation of these outcome studies.
So maybe this isn't a fair question, but I'm still going to ask it because I don't really follow the inoculum effect literature. But it seems like there's been a lot of discussion out there for many years, if not decades, about this effect. So why do you think that we haven't had one of these studies, prospective, randomized, kind of undertaken previously?
That's a really good question. I know that Dr. Aureus's group has extensively studied the inoculum effect, and he is going to be hopefully getting some R01 funding to be able to actually do a proper study looking at outcomes. And so I wonder if it's related to funding, getting funding to actually do the studies properly. So that's what I can think of.
Mm-hmm.
But you're right. Why hasn't this been looked into further sooner? Because we've known about the inoculum effect for decades. So it's a good question, and I don't know fully the answer to it.
Sure. And to be clear, there's inoculum effect not just with cefazolin and MSSA, right? It's not a unique bug-drug combination issue. It's seen with other antibiotics and gram-negatives. And likewise, no clear clinical impact has been identified as of yet, right?
You got it. Yeah. So it seems to occur with beta-lactams. And as you say, with gram-negative organisms, it has been observed. And it always seems to be associated with the presence of a beta-lactamase. But again, the outcome studies are really lacking. Yeah.
Very interesting. Well, I will give the listeners a little teaser that we may be doing a crossover episode with Cesar Aureus for our next episode. We have a really interesting subject that Cesar suggested. It was not the inoculum effect, but maybe we'll slip in a few questions for Cesar if we can. I'm sorry that Susan wasn't able to join us. We'll have to have her back for another subject in the future. But in the meantime, Tanis, thanks so much for joining us. This has been terrific.
Thanks so much for having me. It was a pleasure to be here.
Thanks. And Ellie, great to see you.
Good to see you too. Until next time.
Until next time. And thanks for listening.